Okay, so now we will see about the OVEMP. You're looking at the pathways of the OVEMP. So it is coming from the utricle. Here they have said about the saccule, but these responses are not stronger. In the CVEMP also, we have some responses coming from the utricle, but again, those are not dominant. So we generally say that the CVEMP responses are from the saccule and the OVEMP responses are from the utricle. It's like the dominant one. So utricle is sending its responses to the vestibular nucleus, and from there it is sending to the uh, third cranial nerve, and from there it is reaching your inferior oblique muscles as well as the inferior rectus. I think you all remember the muscles, extraocular muscles connected with the eye when we saw about the ENG, VNG. So we have six muscles, four rectus and two oblique. We have superior inferior rectus and your medial lateral rectus, and then your superior oblique and inferior oblique. So this OM is from the inferior oblique. Okay, IO. So this is the placement when we are doing an OVEMP. Um, one thing I would like to say is the OVEMP is a recent one. The CVEMP was actually discovered in 1990s, okay, by Colbatch et al. And then the OVEMP is actually reported in 2012. Okay, so much of research is done on the CVEMP, and then compared to the OVEMP. OVEMP is like 7 to 8 years old, and CVEMP is like 30 years old. So we have enough um, kind of protocols to record CVEMP, and we have clear clinical applications for the CVEMP. But as regards OVEMP, we are recording it with a limited application, but it still serves a purpose. Okay, so with that, we see the montage for OVEMP. Since we are recording from the inferior oblique, okay, we are going to keep the active electrode on the orbit of the eye. Okay, fine. So when we look up, okay, what happens actually? This is going to contract, this superior rectus is going to contract, and your inferior oblique is going to get relaxed. Okay, so the muscle will come outside. When you look at this orbit, when you keep touching, you have a bony ridge here. Okay, so you're going to check the patient's bony ridge like this. Don't poke into the eye, just check like this. And then once you have checked like this, and you're going to keep your positive electrode very close to the ridge. So when we look up, the muscle will come outside. Okay, the muscle is inside now when I look straight. So that's why I ask the patient to look up 30 degrees. So the muscle will come little outside. So the muscle will be like this and the electrode will be close. Okay, that's the reason. If you don't ask the patient to look up, the muscle will be inside. The distance between the electrode and the muscle will be very far, and already the potential is very less, so we will not be able to record it. Okay, the responses will be poor, and we are going to keep your active or recording a positive electrode close to this ridge and just below it. There are studies that say what is the distance between the active and the reference electrode, but we really don't need to measure these centimeters. We have to just keep it below, provided it doesn't touch. The two electrodes should not touch. If it touches, it is shorting. We are not going to record anything. Okay, so we are going to keep one at the ridge here, and then we are going to keep one just below it without touching it. Not very, very low. We're going to just keep here and then one here. Okay. So again, the ground in the forehead. And one interesting thing is this is not an ipsilateral response. This is a contralateral response, because previously when we gave stimulus to the right side, we recorded from the right ipsilateral, right SCM. But here, when we are going to stimulate the right side, we are going to record responses from the left side. Okay. Fine. So the recording parameters is almost similar, just the filter setting change, which is previously it was 30 to 2000, here it is 1 to 1000. Okay, and then the number of sweeps, again we can have less number of sweeps like 200 or 250, which is enough because this is a muscle potential. But however, compared to the CVEMP, the activity or the response amplitude is going to be reduced. So it is better that we have more number of sweeps than the CVEMP for OVEMP. So we have extended till 500. Okay. Then the artifact rejection is set at 36 microvolt so that we don't record any eye related the blink responses. Okay. And also whenever there is a response, muscle artifact, we always use alternating polarity. We don't use rarefaction polarity. Okay. And then again, the stimulus is going to be higher. And then the rate is again 5 Hertz. The most important thing is vertical gaze angle 30° from the midline. So you have to see exactly 30° midline, not on the right or left. You have to look up and in the center, not on the right up or left up. Okay. Okay, so the VEMP, the characteristics of this OVEMP response is it's an excitatory response. Why do I call it as excitatory response? Because when I see the nerve fibers, when I record the nerve impulse, we have a increase from the spontaneous rate. That's why we call it as the excitatory response. And the value, the amplitude of this response is close to 5 microvolt and can extend till 20 microvolt. Okay, and it declines with age. Okay, so age is a factor. Previously, we had CVEMP, which is affected by the age because the contraction cannot be made. Otherwise, there is no problem with the responses and the changes in the responses with age, but this OVEMP changes with age. Okay, so what do we have here is we have here the OVEMP responses. The down one is the ipsilateral responses. As we said, this OVEMP is a contralateral response, not an ipsilateral response. So you have not recorded anything or a small change. If you look here, you have a small change here, which is not clinically significant. So we don't use that anymore. We are concerned about the contralateral side recordings. Okay, here we are more concerned about the first peak. Okay, not this one. Why not this one? We don't know, because as I told you, there is no much of research done on the OVEMP. So when the authors reported we have to consider this. So we just agree with what the author said before we do our own research and find out. So this will be N1, this will be P1. The latencies of this will be 10 and 15 millisecond. This will be a 10 millisecond, this one will be 15 millisecond. Okay. And as I told you, we are checking at the histogram. So we had excitatory response. This is this one. Your red one is your responses from the inferior rectus, and this one actually is from the inferior oblique. And we are looking at the gaze up and gaze down. Okay. So what happens here? When there is a gaze down, we are going to have a better responses. But when it's a gaze up, we didn't have anything, right? We didn't have any responses. So again, the responses is close to 5 microvolt. Okay, fine. So again, the application of the OVEMP is very limited. Again, there are better responses when there is an superior semicircular canal dehiscence, because this is all connected ones. The endolymph, there's a third window, then we are going to have less impedance and better responses. So we can use it for SCD and for the confirmation of caloric test. How do I say that? The caloric test of the horizontal canal is through the superior part of the vestibular nerve. And to confirm if the superior part of the vestibular nerve is intact, I can use the OVEMP, because the OVEMP also sends its responses through the superior part of the semicircular canal. If both the horizontal canal caloric test and the OVEMP are showing normal results, That means that the superior vestibular nerve is normal. Okay, so it is useful in confirmation of the caloric test, in the confirmation that the superior part of the vestibular nerve is intact. The same can be used to say that the infection is spread to the superior part of the vestibular nerve, as well as if there is any tumor in the superior part of the vestibular nerve. Okay, so how is this VEMP better than the other vestibular test? One reason for easy adoption of this test is because we don't require any special instrument. We really don't want ENG instrument or a VNG instrument. We don't need VH instruments. All these are separate instruments. We have to invest lakhs and lakhs on it. But as we got VEMP, it is a simple test which use the same electrophysiology instrument we use for ABR, ASSR, LLR, MRR, everything. So it's like one of easy potentials which can be recorded in every clinic. And with the CVEMP and OVEMP recorded together, we can comment on the nerves, the how the nerves are intact, the superior and the inferior vestibular part of the vestibular nerve. But in case if there is a complaint of vertigo, we have nystagmus, then VEMP is not useful. So, okay, so we definitely need to perform the ENG, VNG to understand more about this complaint of the semicircular canal. But anything to do with to check the otolith organs, sacral and utricle, VEMP is a good VEMP is a good test. Also, we can record. See, we have modules which we purchase. When we purchase an instrument, we don't purchase all the modules. We purchase only modules which we require. Few clinics don't need ECOG. Few clinics don't require ASSR. So what they do, they buy only the ABR and then they buy only the VEMP or something related to them. What in case if the patient, if the clinic has not bought the VEMP protocol, they don't have this VEMP with them, and they have only ABR. If it's a single channel, then the single channel doesn't allow us to really change the filter setting. It doesn't allow us to change the filter setting. If it's a dual channel, then yes, very good. We can change the filter setting, because for OVEMP and CVEMP, we need filter setting to be changed when compared to the ABR, right? So what do? We use the same ABR page, The only difference is we will not be able to see the biofeedback, whether the contraction is being made sufficient or not. And provided you see that the muscle is very strengthened, you visually inspect the muscle, it is contracted, then I think it is enough to start the test, and we will be able to record the VEMP responses. Again, we cannot rely completely on this method of using the ABR protocol for our VEMP responses. Why? Because as we saw, we rely on the asymmetrical ratio to say if the VEMP responses are normal or abnormal. When the contraction made, we don't have any quantification of this contraction. Previously, at least we had the EMG monitor. At least we don't have the rectification. We had the monitor, but now without monitor and without this rectification in the software, we may be having this kinds of asymmetry because of the muscle contraction, which may diagnose as pathologic. Okay, so is it possible to record without VEMP module? Yes, we can record with the ABR module, but we really cannot rely on the responses. Okay, so I think that's it. Yeah. Any doubts in this?